The palpation method is used when examining the skin of the muscles of the lymph nodes. Studying physical properties of tissues and organs. And the topographical relationships. Palpation is especially important in the diagnosis of some diseases of the abdominal cavity organs. From the heart. Palpation of the heart allows to judge about hypertrophy and dilatation of its various departments, as well as the state of the main vessels.
The left ventricle is examined in the area of the apical impulse. Inhale, exhale, lean forward. First, use the palm of the right hand to get a general palpatory sense of the apical impulse, then determine its location, strength, and area. The right ventricle, when hypertrophied and dilated, can be palpated in the area of the absolute cardiac dullness, cardiac impulse, and epigastrium. Inhale, exhale, lean forward. The cardiac impulse is palpated at maximum exhalation and epigastric pulsation at the patient's deep inhalation. In a healthy person, the pulsation of the aorta is not detected. It may only be identified in the case of an aneurysm in the second intercostal space, to the right of the sternum, or in the jugular notch. To determine diastolic thrill at the apex in mitral stenosis, the examination is performed with the patient lying on their left side. And systolic thrill on the aorta in its stenosis in a vertical and leaned forward position. Let's get acquainted with the abdominal palpation method, which is based on principles developed by Vasily Parmenovich Obraztsov and Nikolai Dmitrievich Strozesko. The first stage of palpation is superficial orientational palpation. By palpating symmetrical areas of the abdomen, the doctor determines the tension of the abdominal wall, painful areas, and the condition of the subcutaneous fat tissue over the organ affected by the inflammatory process. There is usually tension in the abdominal wall and a positive Shachetkin-Blumberg sign. This palpation also allows determining the separation of the rectus abdominis muscles. The purpose of the second stage of systematic deep sliding palpation is to determine the position, shape, consistency, mobility, and tenderness of the abdominal organs. Deep palpation must be performed in a specific sequence depending on the frequency of organ palpation. First examine the sigmoid colon, then the cecum transverse colon, and ascending colon. Descending colon and stomach. The doctor palpates the sigmoid colon. The study is conducted according to specific rules, including 4 main points of palpation. The first point is the placement of the doctor's hand. The second is the shifting of the skin. The third point is the immersion of the hand deep into the abdomen to its back wall. And the fourth point is gliding, essentially palpation. Positioning the hand, moving the skin, penetrating into the depth of the abdomen, palpation. The cecum is palpated using the same method. Inhale, exhale. Hand placement. Sliding the skin, immersion into the depth of the abdomen. Palpation. To reduce abdominal wall tension, using the Obraztsov method, press the left hand on the anterior abdominal wall in the navel area. By percussion palpation of the transverse colon, the lower border of the stomach is found. It is identified by the disappearance of the so-called splashing sound and is located 3 to 4 centimeters above the navel. The border of the stomach can be determined by the ausculto-affriction method through a sharp weakening of sound. The palpation of the transverse colon is performed 2 centimeters below the previously found stomach boundary. The skin is shifted upward, fingers sink into the abdomen, and slide downward along the colon. Hand positioning, sliding the skin, deep penetration into the abdomen, palpation. Bimanual palpation, according to Vasilenko, is used for palpating the ascending colon. Inhale, exhale. The descending colon is also palpated. Positioning of the hand, shifting of the skin, pressing into the abdomen, palpation. The stomach is palpated at the level of the previously found lower boundary of the stomach, along the linea alba and to its side. Once more, inhale, exhale. Before palpating the liver, the lower border is percussed at the mid-clavicular line. To limit rebreathing and increase diaphragm excursion, the patient's hands are placed on the chest, and the doctor's left hand encircles and compresses the costal arch. Inhale. Exhale. Liver palpation is performed during a deep inhale by the patient. The right hand moves the skin. On exhalation, it sinks into the abdomen, forming pockets with the abdominal wall. On inhalation, the liver descends, approaches the fingers and slides off them. Positioning the hand, shifting the skin, forming a pocket from the abdominal wall, palpation. Palpation of an enlarged spleen, based on the same principle, is performed with the patient lying on their back or right side. Positioning the hand, shifting the skin, forming a pocket from the abdominal wall, palpation. During bimanual palpation of the kidneys, on exhalation, the doctor's hands come together, and on inhalation, they capture the lower pole of the kidney and slide down it. Setting up the doctor's hand, bringing them together on the exhale. Grasp the lower pole of the kidney and palpate. Among the various percussion methods, finger-to-finger percussion has become the most widespread. As it is known, dense organs produce a dull percussion sound, while organs containing air like the trap space produce a tympanic sound. A clear pulmonary percussion sound differs from symphonic by a more musical tone. The standard for clear pulmonary sound is the subscapular and axillary area. During the softest percussion, sound waves penetrate by 2 to 2.5 centimeters. At low volume by 3 to 4 centimeters. And at high volume by 5 to 7 centimeters into the organ. To detect pathological changes in the lungs, comparative percussion is used. Loud percussive taps are applied to symmetrical areas of the chest. First, the percussion sound over the lungs in the front is compared, then in the axillary regions. And finally at the back, a healthy person has the same clear lung sound over symmetrical areas of the lungs. A dull or muffled percussion sound over the lungs is detected with inflammatory consolidation of a lung lobe. Or when fluid appears in the pleural cavity, hydrothorax, a symphonic sound when air enters the pleural cavity in pneumothorax. Or if there is a cavity or abscess in the lungs. Quiet topographic percussion is used to determine the boundaries of the lungs. Watch how the determination of the respiratory excursion of the lower lung border is performed. First, determine the lower border of the lung during calm breathing. Then, with a deep breath, and at maximum exhalation. Normally, the respiratory excursions of the lungs are 6 to 8 centimeters. We start heart percussion by determining the right border of relative dullness. First, determine the height of the diaphragm position. Then above this level, they find the right boundary. The left border of the heart is determined by percussion in the fifth intercostal space. 1 centimeter above, stepping back from the left edge of the sternum. After this, the borders of the vascular bundle in the second intercostal space are identified. Then they obtain the outlines of the relative cardiac dullness by percussing in the third and fourth intercostal spaces on the right and left of the sternum. By connecting all the points, the contours of the relative dullness of the heart are obtained. Shift of the borders to the right indicates dilation of the right atrium and ventricle. To the left ventricle, and upwards the left atrium. To determine the borders of the absolute dullness of the heart, a finger pleximeter is placed on the points of the found boundary of relative dullness, and percussion is performed with the quietest percussion. This way, they find the right, left, and the upper border of absolute dullness, connecting the found points provides an idea of the dimensions of the absolute dullness of the heart. An increase in its area is observed with right ventricular dilation. To determine the absolute dullness of the liver using the reference method of Estrajesca, first locate its upper border through silent percussion along the right parasternal line. Normally, it is located at the level of the sixth rib. In the same way, determine the upper boundary along the midclavicular line at the sixth rib and along the anterior axillary line at the seventh rib. Then depercuss the lower border of the liver along the right parasternal line. It is located 2 centimeters below the costal arch, on the midclavicular line at the level of the costal arch, and on the anterior axillary line, the 10th rib. Along the anterior midline, the lower edge of the liver is located at the boundary between the upper and middle third of the distance between the navel and the xiphoid process, and along the left costal arch at the level of the left parasternal line. The found points allow determining 3 dimensions of liver dullness. Along the right parasternal line, normally 8 to 10 centimeters, along the midclavicular line, 9 to 11 centimeters, and along the anterior axillary line, 10 to 12 centimeters.
Auscultation is an indispensable method for diagnosing diseases of the lungs, heart, and blood vessels. During direct auscultation, sounds are hardly distorted, but are perceived from a larger surface area.
The so-called mediocre auscultation proposed by Laennec is conducted using a stethoscope. Or stethoscope. It allows for better localization and distinction of sounds of different origins in a small area. When listening to the lungs, first pay attention to the nature of the main respiratory sounds. Normally, over symmetrical areas of the lungs, vesicular breathing is heard, resembling the sound of rustling. It occurs during inhalation and the first third of exhalation due to vibrations of the alveolar walls. The axillary and subscapular areas are the standard for vesicular breath sounds. Laryngotracheal breathing is heard over the epiglottis and trachea, occurring when air passes through the vocal cords. It has a coarser tone and resembles the sound kh. Pathological weakening of vesicular breathing is observed when there is a fluid accumulation in the pleural cavity. When the lobe of the lung is inflamed and consolidated, bronchial breathing is heard. And in the presence of a cavity or abscess, amphoric breathing. In addition to changes in primary breathing, adventitious breath sounds can be heard over the lungs. Right now you hear dry wheezing in a patient during an attack of archaic asthmas. They are formed as a result of bronchial spasms and their narrowing by viscous exudate. When there is an accumulation of liquid secretion in the bronchi, moist rales can be heard over the lungs. If a small amount of liquid secretion appears in the alveoli, crackles can be heard. They occur when the alveolar walls stick together at the peak of inhalation. A auscultation of the heart begins with listening to the apex. To distinguish the first sound from the second, the acoustic phenomena are compared with the apical impulse or pulsation of the carotid artery. Next, listen to the aorta, the pulmonary artery, tricuspid valve, and again the aorta at the additional Butkener point. Aortic valve lesions are better detected during auscultation in the vertical position with the body bent forward. And pathology of the mitral valve in the position of the patient on the left side.
Normally, at the apex, the first tone is louder than the second. The first systolic tone consists of several components: valvular, muscular, and vascular. As a result of the closing of the atrioventricular valves, the tension of the ventricular muscles, and vibrations of the walls of the aorta and pulmonary artery at the beginning of ventricular systole. First sound, second, first sound, second. Normally, at the base of the heart, the second sound is louder than the first. The second diastolic sound occurs as a result of the closing and vibrations of the semilunar valves of the aorta and pulmonary artery. First tone, second tone, first tone, second tone. In mitral valve insufficiency, there is a weakening of the first heart sound and a systolic murmur, which radiates to the left axillary area. It occurs due to the regurgitation of blood from the left ventricle into the left atrium. First tone, noise, second tone. First tone, noise, second tone. With mitral stenosis, a snapping first sound, the opening snap of the mitral valve, and a diastolic murmur are heard at the apex. The murmur occurs due to the difficulty of blood flow through the narrowed left atrioventricular orifice. First sound, the second sound, click, murmur. The first sound, the second sound, click, murmur. An accent and splitting of the second sound are heard on the pulmonary artery in mitral stenosis. They occur due to increased pressure in the pulmonary artery and the asynchronous closing of the semilunar valves. First tone, second tone, first, second. In aortic stenosis, there is a weakening of the first and second heart sounds and a harsh systolic murmur at the aorta, radiating to the neck vessels. The noise arises as a result of the narrowing of the aortic orifice and the obstruction of blood flow from the left ventricle through the aorta. We have demonstrated to you some physical examination methods, including palpation, percussion, and auscultation. Despite the widespread use of instrumental and laboratory studies in the clinic, these methods remain fundamental in diagnosing human diseases